At any given time, 50% of the population has some chronic condition that requires medical management. This is not confined to the elderly. More than a third of young adults between 18 and 44 have at least one chronic illness. Most eventually develop at least one chronic disability or disease, which may ultimately be the cause of their death. People with a chronic disease tend to see their disease as acute. Researchers have not been successful in identifying clear-cut stages of coping with chronic illness. People with a chronic disease are less likely to seek medical treatment than those with an acute illness. And people who use multiple strategies cope better with the stress of chronic disease than those who use fewer strategies. Lepowski in 1970 described the following ways that individuals view illness and how this meaning can influence emotions and coping. Challenge: a situation with tasks that needs to be mastered. Enemy: invasion by harmful forces. Punishment: just or unjust. This is especially true for young children. Weakness: a sign of failing. Relief: respite from demands or conflicts. Strategy: coping technique for getting attention from others. Irreparable loss or damage: an opportunity for growth or development. Quality of life: for many years, quality of life was measured only in terms of length of survival and signs of presence of disease. This was until the last decade, where it was mainly assessed by physicians, but their ratings are only weakly related to patients' or relatives' assessments of quality of life. Quality of life is considered to have several components. Physical status and functioning. Psychological status. Social functioning. Disease or treatment-related symptoms. Research has produced a few reliable and valid measures for quality of life. The Sickness Impact Profile, SIP, and Medical Record, SF-36, are widely used measures. Here is a sample item from SF-36. Interviews ask subjects to rate quality of current lives using 0, worst imaginable, to 100, best imaginable scale. Why should we study quality of life? Documenting exactly how illness affects activities of daily living, vocational, social activities provides a basis for interventions designed to improve quality of life. Quality of life measures can help pinpoint which problems are likely to emerge for patients with particular diseases. It's helpful in anticipating the kinds of interventions that might be required. It's important to assess the impact of treatment on quality of life. As an example, cancer treatments may produce adverse side effects, perhaps more harmful than the disease itself. Quality of life information can be used to compare therapies. Two may have similar survival rates, but one may lower quality of life more. It is useful for policy-making decisions, important to treatment decisions to maximize survival with highest quality of life possible. It is used in determining cost-effectiveness of different interventions given different quality of life info. Note: the disability paradox. Across a wide range of conditions, patients typically report greater happiness and quality of life than do healthy people imagining themselves under similar circumstances. There are many reasons for this, such as focusing illusions, thinking of the bag after colostomy or only of the wheelchair after paralysis, and underestimation of the ability to adapt. Ubel in 2005 found, across a wide range of studies, self-reports are largely accurate. People with chronic illness are happier than what healthy people predict they would be under similar circumstances. These findings have important implications for treatment. Focusing illusions are difficult to eradicate, An adolescent may not want chemo because they can't imagine living life without their hair. Further research should examine ways to get people to imagine themselves in unfamiliar health states and to recognize the power of adaptation. Smith in 2009 studied overall life satisfaction and quality of life among 107 patients who had recently received either a colostomy or ileostomy. Both involve removal of part of the colon with waste being discharged into a bag the person wears under their clothing. They were interviewed in the hospital and then given surveys 3 times over a 6-month period. Overall life satisfaction and quality of life increased with time for patients with permanent but not temporary ostomies. Why might this be? Knowing an adverse situation is temporary can interfere with adaptation, leading to a paradoxical situation in which people who are better off objectively are worse off subjectively. Chronically ill patients are more likely to suffer from depression, anxiety, and distress. Depression and distress contribute to increased risks for mortality from chronic conditions. There's a temporary first phase when all activities are disrupted. They also need to make intermittent or permanent changes. Immediately after diagnosis, patients are often in a state of crisis. They may experience disorganization, anxiety, fear, etc. Eventually, they develop a sense of how the chronic illness will alter life. Note: from the Handbook of Stress Science in 2011, multiple interventions have been studied, such as stress management strategies and coping skills. The problem is the majority of clinical trials incorporate multiple treatments, so it is hard to know which one is responsible for which positive effects. Stress reduction attempts have somewhat different goals depending on the particular disease. For example, among cancer patients, typical stress reduction efforts center around improvement of quality of life rather than on affecting physical health. Because of the more direct effects stress is hypothesized to have on etiology and course of other CIs, such as type 2 diabetes and CVD, stress reduction interventions have been evaluated in terms of their impact on stress and health outcomes, cardiac morbidity rates, glucose levels. It is important to recognize the value of reducing stress as a goal in and of itself. One should not conclude that an intervention is not worthwhile if it does not have positive effect on morbidity and mortality. Reducing psychological distress and/or a poor quality of life has value, and that value should not be ignored by focusing exclusively on physical health outcomes. Denial. The diagnosis may be so disorienting at first that it's impossible for a person to imagine all of the changes that will be required. The patient may act as though the illness is not as severe, that it will go away, or it will have few long-term implications, and in extreme cases deny it exists. This is commonly observed among heart, stroke, and cancer patients. Whether denial is beneficial or not depends on the stage of illness and how adjustment is measured. There is no research showing that it goes from becoming adaptive to maladaptive at a particular time point. Pros of denial. During the acute phase, it may be protective. It keeps the patient from having to come to terms with the illness at a time when they are least able to do so. Cons of denial. It may act as a deterrent to seeking proper treatment. During rehabilitation phase of illness, denial may have adverse effects if it interferes with the ability to take in necessary information that is part of a treatment or self-management program. Immediately after diagnosis, anxiety is a common response. Anxiety may also arise intermittently, like with asthma. The patient may be debilitated by their emotional distress if anticipating noxious therapy. An example, right before having to get another dose of chemotherapy. Some may need to take medications to help ease their anxiety. Anxiety is high when waiting for test results, receiving diagnoses, awaiting invasive medical procedures, anticipating or experiencing adverse side effects, feeling dependent on health professionals, experiencing concern over recurrence, lacking info about the nature of the illness and its treatment. Depression is the most common reaction. Up to 1/3 of all medical inpatients with chronic illness report at least moderate symptoms of depression, while up to 1/4 suffer from severe depression. There's a strong link between depression and cardiovascular disease. It may be a delayed reaction because it often takes time for patients to understand the full implications of their condition. There's a strong link with non-adherence, impacting long-term rehab and recovery. Assessment of depression can be problematic. Many physical signs of depression may also be signs of disease or side effects of treatment. Depression may go untreated. Often this happens because many believe that one is supposed to feel depressed after a diagnosis of a chronic illness. Predictors of depression: severity of illness, extent of pain and disability. It is important to note that efforts to delineate stages have been unsuccessful. It is more productive to understand what emotions occur, when they are most likely to occur, what factors most likely give rise to them, and whether or not they impede or promote goals of recovery and treatment management.